Hello students, I am Dr. Gokulapriya, Assistant Professor, Department of Pharmacology, School of Allied Health Sciences, WIMS Hospital Campus, Salem. Today I am going to take the topic on insulin and anti-diabetic drugs, or we can call it as OHA, oral hypoglycemic agent. So before moving into the drug part, we should know about the disease, right? Yes. So what is diabetes? So diabetes is a very common health problem that we are encountering in a normal day. Even our parents or the persons who are in our house are also experiencing this kind of problem. So moving into the introduction part, this is a metabolic disorder characterized by hypoglycemia. So hypoglycemia means increased glucose level in the body. So in that is fasting plasma glucose, which is greater than or equal to 126 mg per dl and or / equal to greater than or equal to 200 mg per dl 2 hours after 75 gram of oral glucose. So these are the tests that are used to detect whether there is a hypoglycemia in our blood. Next, glycosuria, so increased glucose level in the urine, hyperlipidemia, negative nitrogen balance, and sometimes ketonemia. So it is a metabolic disorder, so it should be containing all these components, or especially the hypoglycemia and glycosuria. So if these symptoms are present or if these conditions are there, it may be lead to diabetes mellitus. So moving into the types. So there are two major types of diabetes mellitus, that is type 1 diabetes and type 2 diabetes mellitus. So type 1 is slightly differ from type 2 diabetes mellitus because type 1 is majorly due to an autoimmune condition, and type 2 diabetes mellitus is a normal. 90% or majority of cases that we are seeing nowadays is type 2 diabetes mellitus. Here we will be seeing the types. Type 1 diabetes mellitus, otherwise we will be calling it as insulin dependent diabetes mellitus, IDDM, or juvenile onset diabetes mellitus. So juvenile is literally the patient, the younger patients before 18 years of age, they are encountering diabetes is called as juvenile onset diabetes mellitus. So in this type 1, there is a beta cell destruction in the pancreatic islets. Majority of the cases are due to autoimmune, that is type 1A antibiotics that destroys the beta cells are detectable in the blood, but some are idiopathic. So idiopathic means generally the reason it is maybe caused due to any unknown causes or something is known as idiopathic, that is type 1B. No beta cell antibody is found. So in major cases of type 1 diabetes mellitus, our body will be producing an antibodies against the beta cells of pancreas. Why it is producing such kind of antibiotics against the beta cells? Beta cells is responsible for insulin production in our body. So antibiotics are produced and it destroys the beta pancreatic cells. So if the beta pancreatic cells are destroyed now, insulin production will be reduced or it will be insufficient, so that glucose cannot be managed. So if this happens now, it will lead to increased glucose level in the body, that is hyperglycemia. So moving to type 2. So type 2 is a non-insulin dependent diabetes mellitus. So this does not primarily depend on the level of insulin in the body, but type 1 is primarily dependent on the insulin level in the body. So the drug of choice for type 1 diabetes mellitus is always an insulin. Next, type 1 is a juvenile diabetes, that is it affects the younger patients. So it is a maturity onset diabetes mellitus, that is this kind of diabetes can happen after a certain age. Like nowadays we can see the patients or 30 age or getting diabetes, that may be due to their lifestyle, sedentary lifestyle, or their eating habits or lack of physical activities. So these are the major complication factors that may be affecting or that may be a prognosis for type 2 diabetes mellitus. So there is no loss or only moderate reduction in the beta cell mass. Insulin in circulation is low, normal, or even high. So even it can be a moderation or modification in the insulin level, or it may be normal or it may be very high. So these are the two types of diabetes mellitus, type 1 diabetes and type 2 diabetes mellitus. So type 1 is insulin dependent, type 2 is non-insulin dependent. So this is the paracrine modulation of hormone secretion within the pancreatic islets of Langerhans. So insulin is the major hormone responsible for the management of glucose level in the body. So insulin is secreted from the beta cells of pancreas, that is beta cells of islets of Langerhans in the pancreas. So that is the place where insulin is produced and it is stored. So it is not secreted. There should be a signal for secretion of insulin. So that will be discussed in the further slides. So there is 3 types of cells in the pancreas, that is alpha cells, beta cells and delta cells. So alpha cells will be secreting glucagon, beta cells will be secreting insulin and amylin, and delta cells will be secreting somatose acid. So this is a paracrine modulation, that one hormone will be stimulating the other and one will be suppressing the other. That is the feedback mechanism or something we will be calling. That is one, the red line indicates the stimulation and the blue line represents the inhibition. Okay. So this is GLUT family. Before moving into GLUT family, we should need to understand about insulin. As I told earlier, insulin is a hormone. So insulin was discovered in 1921 by Banting and Best, who demonstrated the hypoglycemic action of an extract of pancreas prepared after degeneration of the exocrine part due to ligation of the pancreatic duct. So insulin was first discovered by Banting and his friend Best. So they didn't even complete the whole process and the synthesis. They first discovered there is an organ called pancreas and it has a hormone that is named as insulin, that is during the ligation of a pancreatic duct. So insulin is a 2-chain polypeptide having 51 amino acids and molecular weight of about 6000. The A chain has 21 while the B chain has 30 amino acids. So there will be 2 chains in insulin. I will be showing the picture in future slides. A chain will be having 21 amino acids and the B chain will be having 30 amino acids. But while before the formation of insulin, there will be 3 chains, A chain, B chain and C chain. While A chain and B chain and C chain are formed, it need to be as insulin C chain should be detached from the A chain and B chain. So first is an A chain, connecting peptide is a C chain and B chain. So if it has to be an insulin, this connecting peptide C chain has to be extracted from A chain and B chain. So how this process happens means I will be explaining in the before slide. So insulin is synthesized in the beta cells of pancreatic islets as a single chain peptide pre-proinsulin. So first formation is pre-proinsulin. So this pre-proinsulin will be converted into proinsulin. So this pre-proinsulin has A chain, B chain and C chain. This pre-proinsulin will be converted into proinsulin. After its conversion, the connecting of C peptide is split off by proteolysis. So what is proteolysis? Lysis means breakdown, proteo means proteins. So the proteins will be breakdown. The proteins will be breakdown in the Golgi apparatus. So in that Golgi apparatus, this pre-proinsulin and converted to proinsulin, and that proinsulin, after it is splitting its C chain by proteolysis in the Golgi apparatus, inositol and C peptide chains are formed. So now here the process is like, first the formation is pre-proinsulin, from the pre-proinsulin, proinsulin will be formed, and from that proinsulin, insulin will be formed. So now insulin is formed. So where it will be stored? So insulin will be stored in the granules. It will be stored in a sac like vesicles. So inside that vesicles there will be insulin stored inside the beta pancreatic cells. So when this insulin will be released? So this insulin will be released when our body is sensing a high glucose level. So when the glucose level increases after having a meal or after having something, that food what we are intaking, after that glucose level will be increased. So in order to manage that, there is a system. So that system is called as glucose transporter system. So that is we are going to see in the next slide. So we will be calling it as GLUT family. GLUT is glucose transporters. So transporters in the sense they are going to transport the glucose in the bloodstream into the beta pancreatic cells. Why this transport is important? Because if the glucose is transported in the bloodstream towards the beta pancreatic cells, the beta pancreatic cells or these transporters sense the higher glucose level and they will be releasing insulin. So for that purpose, this GLUT family is very important. So there are 5 types of GLUT transporters: GLUT1, GLUT2, GLUT3, GLUT4 and GLUT5. So GLUT1. So GLUT1 is responsible for basal uptake in RBCs, brain, cornea, placenta. So these are the 4 places where GLUT1 transporters are present. RBCs, brain, cornea and placenta. So this is insulin independent. So what is independent? This transporters does not need insulin for its activation. So that is the reason we are calling it as insulin independent. Next, GLUT2. Higher capacity in liver, beta cells, kidney and intestine. So this GLUT2 receptors are present in liver, beta cells of pancreas, kidney, intestine. This is glucose sensing. So these transporters get activate when they sense a higher range of glucose in the bloodstream. Next, moving to GLUT3. So GLUT3 is present in brain or neurons. Next, and placenta, higher affinity in the placenta. So this is also insulin independent. So GLUT1 and GLUT3 are insulin independent. GLUT2 is glucose sensing. So glucose sensing in the sense when there is a higher range of glucose in the body, these transporters get opened. Okay, next moving to GLUT4 and GLUT5. GLUT4 is present in the heart, muscles and fat. So it is insulin dependent. So what is insulin dependent? So insulin dependent means, so these transporters open only in the presence of insulin. So as I said before, GLUT2 will be open when there is a increased blood glucose level, but GLUT4 will be opening when there is a insulin spike or insulin release. So these are the places: muscles, heart and fat tissues. Moves to membrane only when insulin binds. Yes. So these transporters will be present inside the cells of muscles, heart and fat tissues. These transporters will be moved to the membrane only when they sense a insulin release. Next, GLUT5. So it is a fructose transporter. It is present in the intestine, sperm and kidney. So these are the glucose transporters that need to be known for the entire process. After a meal, how the blood glucose spikes, how the insulin reduces or suppresses the glucose level in the body. So these are a connective mechanism, and these transporters work by linking with each other. So there are 5 transporters: GLUT1, GLUT2, GLUT3, GLUT4 and GLUT5. So GLUT1 and GLUT3 are independent. They are not dependent on insulin release, but GLUT4 is primarily dependent. It is completely dependent on insulin release. GLUT2 is glucose sensing. So what I have told, I will be explaining it as a mechanism. So the process of glucose management system. So after a meal, so when we are taking food, after the completion of a meal, a breakfast, a lunch, dinner, anything, after a meal, glucose level will be increased. As we are primarily relying on carbohydrates, the food we take has a quite large amount of carbohydrates. So these carbohydrates are converted into glucose. So after a meal, so first GLUT2, the GLUT2 transporters, as I told earlier, the GLUT2 transporters are present in the kidney, intestine, beta cells. So here we are going to take the beta cells. GLUT2 in the beta cells senses high glucose. So in the bloodstream, if there is a high glucose now, beta cells will be sensing it as high glucose levels are there. So we have to release insulin, like that they will be sensing. So GLUT2 transporters will trigger the insulin release. As I told before, where the insulin will be stored in the vesicles inside the beta cells. This insulin activates GLUT4. So as I told before, GLUT4 transporters are insulin dependent. When this GLUT2 senses the high glucose and releases insulin, this released insulin will be going to the GLUT4 transporter. After going to the GLUT4 transporter, so the GLUT4 transporter is present in the muscles, fat and heart. So in the skeletal muscles, heart and adipose tissues. So these tissues take up most of the post-meal glucose. This lowers the blood glucose efficiently. So this transporter, this GLUT4 will be asking the muscles, heart and fat to take up the glucose from the blood and use it for energy production, and in adipose tissue it will be stored as a fat. So it will be telling muscles to use it for energy. So energy production, ATP production. Here the mechanism will be compromised. So when a higher glucose level is there, it will be stimulating the heart muscles, skeletal muscles and adipose tissues to take up the glucose and use it for energy. Next, GLUT2 plus insulin plus GLUT4 work together as a team. When the high glucose level in the bloodstream is there, GLUT2 transporter will be sensing the glucose and it will be releasing the insulin. That released insulin will be going to the GLUT4 transporter, and it will be asking or stimulating the muscles, heart tissues and adipose tissues to use up the glucose effectively. So here they work as a team. In fasting state, low glucose, GLUT1 and GLUT3 ensure brain and RBC still get glucose. As brain, it needs to function effectively, glucose should be present. So during the fasting state, when we are keeping a fast or overnight fast, so in that time GLUT1 and GLUT3 will be ensuring brain and RBCs to that they still get glucose. If brain fails to get glucose, brain will not function efficiently. So GLUT2 in the liver allows glucose to be released from liver into the blood via gluconeogenesis or glycogenolysis. So these are the process in biochemistry that gluconeogenesis apna, that is production of new glucose from non-carbohydrate sources. Then glycogenolysis, that is breakdown of glycogen. So GLUT1 plus GLUT2 and GLUT3 work together to maintain basal glucose level. So whenever our body is thriving or it is in the fasting state, these three transporters work together to maintain the basal level of blood glucose. So intestine during absorption, GLUT2 on the basolateral side sends glucose into the blood. GLUT5 absorbs fructose, both help in carbohydrate absorption. So these are the other functions of GLUT2 and GLUT5. So this is the entire process of how a glucose management system works and how all these 5 transporters help in the regulation or the maintenance of blood glucose and the release of insulin and the effective utilization of blood glucose. So here is the summary of the entire process. GLUT2 tells the pancreas to release insulin. Insulin tells GLUT4 to take up the glucose into the muscle and fat. GLUT1 and GLUT3 gives glucose to the brain and RBCs all the time. GLUT5 handles fructose. They form a coordinated glucose management system. So all these glucose transporters are essential and they need to be worked on a connected basis. If one fails, if any transporter fails, then the effective management of glucose will be affected. So this is the transporters, how GLUT4 transporters and glucose transporters work. So this is how the GLUT2 transporter works. So in the right hand side, that is a bloodstream. So in the bloodstream, after we are having a meal, in the bloodstream glucose level will be increased. So after the glucose level is increased, what will be happening? So you can see this side. So it is a beta pancreatic cell. So there is a 3 receptors on these cells. One is GLUT2, that is glucose transporter 2. So the near to that green color receptor is there. It is called as potassium channel, or we can call it as ATP sensitive potassium channel. So ATP sensitive potassium channel. So what is sensitivity? So ATP sensitivity, when ATP is produced, the receptor will be closed, the channel will be closed. So thereafter it is named as ATP sensitive potassium channel. Next another channel is there, that is L-type calcium channel. So these 3 channels are present in the membrane of beta pancreatic cells. When there is a high blood glucose, the glucose will be entering into the beta cells via GLUT2 transporter. So the GLUT2 transporter, after sensing the high blood glucose, it will be opening. So once the transporter is opened, glucose level in the blood will be entering into the beta cells of pancreas. So after the glucose enters into the beta cells, it will be going to mitochondria. So in that mitochondria, TCA cycle will be performed. So this mitochondria will be performing TCA cycle. So that TCA cycle, glucose will be converted into glucose 6-phosphate. Finally ATP will be produced. ATP is adenosine triphosphate, that is we will be calling it as energy. So after the energy is produced, that is ATP is produced. After the ATP is produced, this ATP will be closing the potassium channel. So as I told before, it is ATP sensitive potassium channel. Once the ATP is produced, the channel will be closed. So now here the potassium channel closes. So after the potassium channel closes, the membrane starts to depolarize. So membrane starts to depolarize now. The membrane is moving towards a positive direction. So the membrane potential will be increasing in a positive way. So the membrane depolarization happens. So after the membrane depolarization, it will be opening the L-type calcium channel. So once the L-type calcium channel opens, calcium ions will be flowing from outside the cell to inside the cell. So when the calcium ions, so this is the important part. So when the calcium ions flows inside the cell, it will be triggering the insulin vesicles. As I told before, insulin will be stored inside the vesicles. So these calcium ions will be triggering the insulin vesicles. So from these vesicles, the insulin will be released. So this process is called as exocytosis. Once the insulin is released, it will be entering the bloodstream, and after entering the bloodstream, it will be going to the GLUT4 transporter. So it will be reaching the GLUT4 transporter and it will be stimulating the heart muscles, next muscular muscles, fat, adipose tissues, skeletal muscles to take up the glucose and use it efficiently for its energy production. So this is also the same one. So here there will be the process of TCA cycle. So when the glucose enters into the cells, the glucose will be converted into glucose 6 phosphate that with the help of glucokinase, and the glycolysis will be happening. TCA cycle, that is citric acid cycle, will be happening in the mitochondria, and finally ATP will be produced. So this ATP will be closing the ATP sensitive potassium channel. So after the closing of the channel, membrane depolarization happens. So after membrane depolarization, calcium ion channels will be opened. So after the opening of L-type calcium channels, calcium ion will be flowing inside. It will be triggering the insulin containing granules or vesicles. Exocytosis happens and insulin will be released from the beta pancreatic cells. So this is how, when the high glucose is sensed, GLUT2 transporters work and how they release the insulin. So far we have seen about the normal physiology, how it works. Now we are moving into the drug part. So insulins are divided into, or they are classified into 4 types: rapid acting, short acting, intermediate acting and long acting. So in rapid acting, insulin analogs, insulin lispro, insulin aspart, insulin glucagon. In short acting, regular, soluble insulin. Intermediate acting, insulin zinc suspension, lenti-insulin, natural protamine hexidron, NPH or isophane insulin. In long acting, insulin analogs, insulin glargine and insulin detimer. So these are the types and classifications of insulins. So this has been discussed earlier. So now moving to the actions of insulin. So insulin facilitates glucose transport across the cell membrane. Skeletal muscle and fat are highly sensitive. So as we told, once the insulin is released into the bloodstream, it will be triggering the or stimulating the muscles, heart and the fat tissues to take up the glucose and use it efficiently for energy production. So that is one of the primary action of insulin. Insulin inhibits gluconeogenesis from protein, FFA and glycerol in liver. Insulin inhibits lipolysis in adipose tissues and favors triglyceride synthesis. So these are the common actions of insulin. So actions of insulin producing hypoglycemia. Hypoglycemia is reducing the excess glucose level or high glucose level. So in diabetes mellitus, hyperglycemia will be seen. That is because either insulin level can be normal, high or even low. So how insulin is reducing the blood glucose level? So it is going to happen in 3 places like liver, muscle and adipose tissue. So first in liver, it increases the glucose uptake and glycogen synthesis. It inhibits glycogenolysis and glucose output. Inhibits gluconeogenesis from protein, pyruvate, FFA and glycerol. In muscles, increases the glucose uptake and utilization. Inhibits proteolysis and increase of amino acids, pyruvate, lactate into blood, which form the substrate for gluconeogenesis in liver. Next in adipose tissue, it increases the glucose uptake and storage as fat and glycogen, inhibits the lipolysis and release of FFA and glycerol, which forms the substrate for gluconeogenesis in the liver. So these are the process which we have discussed earlier. So these are the actions of insulin producing how insulin reduces the blood glucose level. So this is the mechanism of insulin. So when insulin is available only in the injection form, so when insulin is injected, that is we are going to inject it as subcutaneous. So it is mainly given in the fatty tissues or fatty layers like upper arm, thigh, stomach, abdomen. So insulin is absorbed into the bloodstream. It binds to insulin receptors on target cells, mainly muscles, adipose tissues and liver. So insulin receptor, it is a tyrosine kinase receptor. So this receptor gets activated. So this triggers intracellular signaling. So there will be an intracellular signaling process like IRS will be converted into PI3K AKT pathway. GLUT4 transporters move to the cell membrane. So as I told before, GLUT4 is insulin dependent transporter. So the transporter will be present inside the cell only. When there is insulin release, the insulin will trigger the transporter and it will be moving the transporter towards the cell membrane. Once the transporter is moved to the cell membrane, the same process will be happening as it is happening in the GLUT2 transporters. So GLUT4 transporters move to the cell membrane, muscle and adipose tissue. Glucose enters the cell. Glucose is used for energy, stored as a glycogen, liver and muscles. It is converted to fat, blood glucose decreases. So this is how the entire process is happening. So this is similar to that of the physiological process, but the drug is given exogenous. That is, we are going to give it as an injectable form. So preparations of insulin. The older commercial insulin preparations were produced from beef and pork pancreas. They contained less than 1% of proteins which were potentially antigenic, that is 10,000 parts per million. Such insulins are no longer produced and have been totally replaced by highly purified pork or beef insulins, recombinant human insulins and insulin analogs. So initially insulin was taken from the pancreas of pigs, beef, that is pork. After that, even it is taken from the animal part, there is a presence of antigens, so that will be triggering our body to produce antibodies against that. So this will be a negative impact. So we are now producing insulin mainly based on the synthesis basis, that is biotechnology, recombinant biotechnology. So that is the process how we are now preparing insulins. So this is the type of insulin preparations and insulin analogs. So types, appearance, onset, peak, duration and can be mixed with. If patient is having uncontrolled hyperglycemia, we have to combine two insulins and we have to give to the patient in order to control their blood glucose level. So first type, rapid acting insulin Lispro, it is clear. So onset is 0.2 to 0.3 hours. Peak is 1 to 1.5 hours, duration is 3 to 5 hours. It can be mixed with regular insulin and NPH insulin. Next, insulin aspart, it is also clear insulin. It has the same onset as compared with Lispro. So everything is similar as Lispro. Next, insulin glucagon, it also appears clear. The onset is 0.2 to 0.4 hours. The peak is 1 to 2 hours. It has a very short duration of action, that is 3 to 5 hours. Regular and NPH insulin can be mixed with glucagon. Short acting, regular or soluble insulin, clear, 0.5 to 1 hour, 2 to 3 hours peak time. Next, duration is 6 to 8 hours. All preparations except insulin glargine and detrimer. Next, intermediate acting. So both are similar. Insulin's zinc suspension or lenti, natural protamine hedgehedron or isophene insulin, both are cloudy, so that is they are opaque. It will not be a clear solution or see-through solution. So 1 to 2 hours onset, 8 to 10 hours peak time, 12 to 20 hours duration. It can be mixed with regular insulin. Next, long acting insulin, insulin glargine, insulin detrimer. So both appears to be clear. Onset is 2 to 4 hours and detrimer has 1 to 4 hours. There is no peak duration for both. Insulin glargine has a duration of 24 hours and insulin detrimer has the duration of 20 to 24 hours. It cannot be mixed with any kind of insulin. So this is the type of insulin preparations and this is their appearance, onset, peak, duration and which insulins can be combined. So this is completely explained in this table column. So reaction to insulin. So what kind of reactions or what are the effects that insulin produces? Hypoglycemia, that is reduced blood glucose level. Local reactions like swelling, erythema and stinging sometimes occur at the injection site, especially in the beginning. So when we are taking any drug through injectable form, there will be a local pain, irritation or erythema. So these are the common reactions to insulin. Edema, urticaria, angioedema and anaphylaxis can be a somewhat higher range of reaction, but usually this does not happen. This is somewhat a rare case, but the previous above 2 or 3 reactions is a very common one the patient can experience. So that is for insulin. So this is oral anti-diabetic drugs or OHAs, oral hypoglycemic agents. So this is majorly divided into 3 types that enhance the insulin secretion, overcome insulin resistant and miscellaneous drugs. So the drugs enhance the insulin secretion is further classified into two types, that is potassium ATP channel blockers, dipeptidyl peptidase DPP4 inhibitors. So the further potassium channel blockers are classified into two types, sulfonylureas and meglitinides. So sulfonylureas, there are two generations, generation 1 and generation 2. Tolbutamide will be coming under the first generation, glibenclamide, glipizide, gliclazide, glimepiride will be coming under the second generation. Meglitinides, repaglinide and natiglinide. Next one, dipeptidyl peptidase DPP4 inhibitors, sitagliptin, vildagliptin, saxagliptin, linagliptin. So these are called as gliptins. Next, overcoming the insulin resistance, it is divided into two types, biguanides and thiazolidinedione. So biguanides contain fenformin and metformin. We are not using fenformin now because it will be causing lactic acidosis, so we are currently using only metformin. Next, thiazolidinedione contains pioglitazone and rosaglitazone. Rosaglitazone is not used now as it is carcinogenic. Next, miscellaneous drugs, alpha glucosidase inhibitors, agarbose, voglibose and miglitol, amylin analog, pramlinitide, dopamine D2 agonist, bromocriptine, sodium glucose cotransporter 2 inhibitor, dapagliflozin. So these are the oral drugs that are taken through the mouth. Insulin is taken only as an injectable form. Oral anti-diabetic drugs are taken through the mouth, mainly as a tablet. So we are going to see about sulfonylureas. So sulfonylureas are the main class of drugs. So we have seen that glibenclamide, glipizide, gliclazide and glimepiride. So all sulfonylureas have similar pharmacological profile. They solve significant action, being lowering of blood glucose level in the normal subjects and in type 2 diabetes, but not in type 1 diabetes mellitus. So insulin can be used in both type 1 diabetes and type 2 diabetes, but oral anti-diabetic medication or oral hypoglycemic agents, so the drugs we have seen so far, it should be used only in type 2 diabetes, not in type 1 diabetes mellitus. Being more potent and clinically superior, only the second generation sulfonylureas are employed. So as I told before, sulfonylureas is classified into two generations, generation 1 and generation 2. Tolbutamide comes under the first generation, glimepiride, gliclazide, glibenclamide, these drugs comes under the second generation. So we are currently using second generation drugs, not a first generation drug. So pharmacokinetics, all sulfonylureas are well absorbed orally and are 90% more bound to the plasma proteins, have low volume of distribution, that is about 0.2 to 0.4 liter per kg. They are primarily metabolized, may produce active metabolite. These metabolites are excreted in the urine. As such, they should be cautiously used in patients with liver or kidney dysfunction. So sulfonylurea should be the patients with kidney or liver failure. We have to use in caution about sulfonylureas, or we can change some other drugs. So adverse effects, incidence of adverse effect is quite low, 3 to 7%. Hypoglycemia. So hypoglycemia is a common ADR of all anti-diabetic drugs and insulin. Gain of weight gain is there, 1 to 3 kgs. Nausea, vomiting, flatulence, diarrhea, constipation, headache, paresthesias are generally mild and infrequent. So paresthesias are the symptoms of pins and needles that we are experiencing in the extremities. Hypersensitivity reactions like rashes, photosensitivity, purpura, transient leukopenia and rarely agranulocytosis. So these are the adverse effects of using sulfonylureas. So this is the mechanism of action, how sulfonylureas are acting. So sulfonylureas will be binding to the potassium and it will be opening. It will be closing the potassium channels, ATP sensitive potassium channel. So the sulfonylureas and meglitinide analogues act on the sulfonyl receptor SUR1, which constitute a subunit of the inwardly rectifying ATP sensitive potassium channel in the membrane of the beta pancreatic cells. The outward flow of potassium ion is thereby restricted, intracellular potassium concentration rises and the membrane is partially depolarized. So after this depolarization, augmenting the calcium channel opening as well as the release of calcium ions from the intracellular stores. The calcium ions promotes the fusion of insulin containing intracellular granules with the plasma membrane and exocytotic release of insulins. Incretins such as glucagon-like peptide 1 and glucose-dependent insulin-tropic polypeptide act upon their own G-protein coupled receptors on the beta cell membrane to activate the adenyl cyclase and generate cyclic AMP, which also promotes exocytosis of insulin. Exenatide and lirunatide are GLP-1 receptor agonists which produces the same response as GLP-1. So this is the normal physiological process, how our insulin is managing, or how GLUT2 transporters, after the performance of TCA cycle, ATP is produced, and this ATP is going to shut down the potassium channel, that is ATP sensitive potassium channel is going to be closed, and after that closed, the membrane will be depolarized, and after the depolarization, calcium channels will be opened, the calcium ions will be coming from the intracellular stores. After the calcium ions are coming inside the beta pancreatic cells, it will be triggering the vesicles that is containing insulin to release the insulin. So the exocytosis process is going to happen. So this is how the sulfonylureas also work. So the next drug is metformin. This comes under the biguanides. Two biguanide antidiabetics, fenformin and metformin, were introduced in the 1950s. Because of higher risk of lactic acidosis, fenformin has been banned in India since 2003. It causes little or no hypoglycemia in non-diabetic subjects, and even in diabetes, hypoglycemia is rare. So it is called as euglycemic rather than hypoglycemic. So far we have seen sulfonylureas and insulin, they will be reducing the glucose level, that is they are acting as a hypoglycemic agent. But metformin is not acting as a hypoglycemic agent, it is acting as euglycemic agent. It is not going to cause hypoglycemia. So mechanism, reducing hepatic glucose production, this is the most important thing. So metformin inhibits the mitochondrial respiratory chain complex 1 in the liver cells. So after this inhibition, ATP levels are low and AMP levels are increased. So once the AMP level increases, this activates the AMP activated protein kinase AMPK. So after this AMPK is activated, it suppresses the gluconeogenesis. So the entire result is less glucose is released from the liver. So next mechanism is it increases the insulin sensitivity in the peripheral tissues. Insulin increases action in the muscles and adipose tissues, enhances GLUT4 mediated glucose uptake, better glucose utilization. So the next one is reduced intestinal glucose absorption. Reduces glucose absorption from the intestine, less postprandial glucose rise. So the adverse effects of metformin, side effects with metformin are frequent but generally not serious, like abdominal pain, anorexia, bloating, nausea, metallic taste, mild diarrhea and tiredness. Vitamin B12 deficiency, lactic acidosis. So these are frequent but they are not generally harm in nature, they are not serious, they can be managed. Indications, so the uses. Metformin is now established as a first drug of choice for all types of type 2 diabetes mellitus patients except who are not tolerated or contraindicated. Infertility. Metformin has been found to improve ovulation and fertility in some infertile women with polycystic ovary. Metformin can be given for the patients with PCOD or PCOS, polycystic ovarian disease. So in that condition also people can be given with metformin other than diabetes mellitus. So this is the approaches to drug therapy in type 2 diabetes mellitus. Improve insulin availability, exogenous insulin, sulfonylureas, meglitinide or phenylalanine analogs, dipeptidyl peptidase 4 inhibitors, GLP-1 receptor agonist. To overcome the insulin resistance, biguanides, thiazolidinediones and alpha-glucosidase inhibitors. So major limitations for improving glucose availability. So multiple daily injections, hypoglycemic episodes, weight gain, concern about premature atherosclerosis due to hyperinsulinemia. So major limitations for overcoming the insulin resistance. So these drugs, inability to achieve normoglycemia by themselves in many patients, especially moderate to severe cases. So this is how we are going to treat the patients with the type 2 diabetes mellitus. As I told before, the insulin level can be high, low or even normal. So every patient is unique individual. So we have to tailor the regimen or we have to tailor the drug therapy according to the individual patient so that the therapy can be very effective. Not every drug will be acting as the same for every individual. So some drug can act very effectively for some patient or some drug cannot produce any action for some patient. So it is completely based on the individual and we have to tailor the regimen according to the individual patients. Thank you students for watching my video.